Day, and we will start now with Judith Mueller for around 30-minute presentation and 50-minute question. 15 minutes. I will be the time master. On va préparer. Est-ce que tu as ta présentation? Je te... Judith, il va falloir juste que tu repartages l'écran depuis. Alors, voilà. Et ça.
Attends, juste reste avec moi parce que. Je pense que c'est bon comme ça. So, good morning, bonjour, good morning, everybody. So, I'll speak in French. It's that was the way it was asked. Some slides are still sorry, I still speak in English, and some slides are still a little bit in French. So my name is Judith Mueller. I am a medical epidemiologist, and as such already outside of the scope of the day today. And I see my role a little bit like, well, I work with social sciences around vaccination, but the talk will sort of take the thing from the end. What actually are we working for? What is at the very end? And as you know, in research, public health research today, it's about evaluating interventions. That's where funding comes in mainly, or what we're supposed to do. And so what actually do we know today about this, and which interventions actually are out there, how to evaluate them. And so I set the frame for the talks that will follow, who will go in much more detail. So I just give an overview of what is out there. So where do these interventions on healthcare professionals, why are they here, and why do we need them? So you see here the dynamic process of vaccine uptake as, well, I represent it for myself when I work with it, sorry. Obviously, so individuals, that's from the patient's view or from the individual's view. Here's the individual with all the luggage. Then there is an offer or information about the vaccination that creates awareness, and actually also the question, should I get vaccinated, which is then the deliberation, which may lead to intention, which can lead to vaccination depending on the barriers, depending on cues to action. And so in green, that's the healthcare professionals, where they come in. They actually are in charge of the offer, the information actually as well, depending on which system you work in. They are today seen as being in charge of the motivational interviewing to accompany the deliberation process, and they may also provide cues to action to actually get vaccinated. Here below here, if you want, there's also the package of what actually where the healthcare professional stands. It's not in this scheme here, but you could also bring this in. So why is there a thing about healthcare professionals? And well, we all know it, but let's just phrase it differently. You know these data, so it's the measure of vaccine hesitancy in the French population. It's already a little bit older, but if you take the different items defined by WHO SAGE, it's actually this one that is the tough one. If people refuse a vaccine that is recommended by the physician, here they eventually get vaccinated, and here if they if they have doubts, they got vaccinated. If they delayed, they also eventually got vaccinated. So this one is the difficult one. But if you just switch it around, here, if 22% of the parents of children say they refused it already at least once, this means that actually more than 70% have not refused and they just get it. And if you go to the HPV vaccination and the flu vaccination, where currently there's really sort of the difficult parts, you could say HPV coverage could be more over 70%, if you just take whether people refuse it or not, and flu coverage in French could be greater than 80%. So it means that there is something happening with the offer, the information, and maybe also the system of acceptability, but especially there's a problem with the coverage, because we are far from these coverage levels. And just to zoom in on HPV vaccination, I will speak about the PREF HPV trial a little bit later. but just at the baseline, so this is not a representative sample, it's a sample that is a little bit more prone to vaccination that participated, but not so much. And you see that among the more than 1,000 parents of students who declared that the student is not vaccinated against HPV, 80% declared having had a recent visit at their GP, and 45% declared never having received a HPV vaccination offer. So that's a big problem. That's why there's something with healthcare professionals. I'll show a lot of studies by Pierre Verger. It's actually Pierre who could have given the overview talk on his work. But in France, there's actually especially Pierre who has worked on healthcare professionals and their practice in promoting vaccines. It's also already older data. It's really striking. It's on GPs, the percentage of GPs who do not systematically recommend a given vaccine. That's the number in red. And you see that it's at least 40% and up to 65%. HPV for girls, 55% of GPs do not systematically offer this vaccine. Seasonal flu, for people who really need it, it's 40% of the GPs do not systematically offer the vaccine. There's a big problem. And if you ask GPs what would they like, what can we do, that's very interesting, and that's maybe already first part of the solution. But they ask for information campaigns in the public, which are difficult to conduct. They want to have argumentaries around benefits and risk, information booklets for the patients. They want to have the vaccines in the cabinet and in the consultation room, which is not the case in France. There is no fridge with the vaccines in. There's a more complicated path. And they also would like to be paid a little bit more for the talk they have to convince people. So first part, what actually should be done around healthcare professionals, and we should not leave this out of, forget about this when we talk here today about psychological aspects, societal aspects. We need policies, we need better policies. And just to think about what would be the solutions of what I just showed you is there could be a mandatory systematic vaccine offer that is imposed on GPs. There is, of course, improved context for vaccine promotion, raising literacy, awareness in the general public, which means going to the schools, putting vaccination higher, doing better campaigns in some way, or doing campaigns, information campaigns, having vaccines in stock at the consultation, and also, and this is being done in France, enlarging the circle of healthcare professionals who can promote, prescribe, and administer vaccines. Now, these are policy changes, and actually, you need to evaluate policy changes. That's what economists like to do and what they know how to do, but actually in France, they don't happen so much, these evaluations. There are experimentation in some administrative regions of France, for example, giving the competencies to pharmacists on flu vaccine. There was an evaluation. It's at best pre-post comparison that leaves a lot of room for interpretation and questions of what is happening actually. And so overall, these policy changes rarely happen, if they happen, they rarely happen in the context of interventional research, which is a challenge. So what can be done? And well, you can, remain a little bit on the question who else could actually do the vaccine promotion, which is the first step. If GPs don't have the time and so on, could somebody else do it? And there's, of course, this concept of health mediators that was also tested in Canada by Arnaud Gagneux, and so this works also in France. Pierre tested this in Marseille with disadvantaged populations. So that's the knowledge score that increases in the mediators, health mediators, when they get training. And there is a before-after change in an intention to get COVID vaccination from 70 to 30%, and in DTP vaccination from 36 to 54%. So this works, and this is actually already good interventional research. Similarly, it's still by Pierre, you can train midwives in the maternity wards to actually promote vaccination. So you take a little bit away the role from the pediatricians and so on. You give it really to the midwives, put them in the middle of the activity. And if you look at vaccine intention score, depending on different levels of initial vaccine hesitancy among the family of the baby, and you clearly see that there's a improvement, a pre-post improvement in the vaccine intention score. So this also, in this pre-post comparison, it's randomized design. This works. However, it's a motivational interview by midwives compared to a leaflet. So it's the motivational interviewing, but it's also the midwife that actually does the work. Somebody in person comes to speak. So there are two components actually to this intervention. And so the question is, which one is most cost effective, which one can be really done everywhere in France. There is also evaluation of things that are like alerts, training, and rate feedback for clinicians. So actually, do clinicians in their consultation, do they know what are their vaccination rates? Do they ever look at this? And so it's an older study from publication from 2013. This works, and here the question was, should it be combined with other interventions on the families? And so overall, they concluded that, so this is the days to vaccination, sort of the Kaplan-Meier curve, the survival, the unvaccinated survival, if you want. And so the combined intervention, combining something focusing clinicians and families worked the best. But you also see that clinician-focused intervention followed closely, and so you had a significant effect compared to no intervention at all. But you also had combined versus clinician only, where it was not really significant, this difference, but probably we should do, and that's also one of the paradigms that is out there, we should have combined interventions, not only focusing on one of the stakeholders. So how to prove vaccine promotion by healthcare professionals? Well, there's training, of course. So there's a lot of syllabi for initial and continued training. It can focus on vaccination, and I would put the shared decision-making questions in, decision-making tools in here as well. You can train them on vaccine hesitancy. ECDC has, for example, working on this as well. And we are here today especially to speak about motivational interviewing techniques, which seem to be those that actually work quite well. These interventions have already been evaluated, at least in specific situations. Here it's about HPV vaccination in US consultations. This is the trial by Dempsey, which remains a little bit the reference for everything that we are doing. This was a 5-component intervention on healthcare professional communication, with a fact sheet library, disease images, decision aid tool, communication training for healthcare professionals, not only MI, but also a presumptive approach, which is then already a more specific technique, and a parent education website. And you see that, and I like this trial especially because it allows you, so the outcome is the uptake. It's not only who thinks what, but it's really actually, do people get vaccinated? And you see that there's a significant increase, be it in the pediatrics consultation, private consultations, and routine checkup. And this also means that actually there is no increase in the family medicine consultation. It's low in the beginning, and it remains low, the coverage. In public practice, it's actually already quite high to start with. Well, it's still 50% only, but that's already quite high and didn't change a lot. And then the sick visit doesn't work. So this is actually the kind of study that not only evaluates the intervention, but also allows you to actually zoom in where it works, where it doesn't work, and then actually go to the next step, what can we improve? But it's complex. If we speak about motivational interviewing, there's also the question, what is actually the content, what the healthcare professionals should say? Because it's a technique on what is my posture, how do I lead the talk, the conversation, but there's actually a big question of what do I actually say? And so here actually we have studies on lay volunteers, but that actually do not involve healthcare professionals, because that's a big challenge actually to do interventional research here. And so there is a talk that Dawn Holford will go more in detail today about the empathetic refutational interviewing. It's here, what the publication that I have is randomized lab experiments, and we will, I'm looking forward to hear more about this today. So there is an increase in vaccine acceptance that can be shown by the specific technique, interviewing technique, or content actually. And there's also something that I've been working on are there don'ts in communication? Are there actually things that are regularly said by healthcare professionals, but actually that don't work and that make it worse? And so here you can actually use scenario-based studies, like vignette studies for psychologists, or for the economists, it's more discrete choice experiments, where you actually compare hypothetical scenarios that are answered by the participant in a row, and you observe what actually happens on vaccine acceptance, depending on what is in the scenario. Very experimental, but maybe as good as we can do it, because afterwards, if you want to do really a full evaluation, you need randomized trial and so on. If you are not sure yet what to actually to communicate, it's just a way of wording it, it's probably not the right thing to evaluate in an RCT. And just to give you an example, it's also about the question, should we actually speak about the benefit-risk balance? That's something that physicians love to speak about when they promote vaccination. The benefit-risk balance is positive, it's favorable, you should get vaccinated. And the problem is, what we found is that it's actually only university degree level healthcare workers who really take this into account when they make decisions about vaccination. Other healthcare professionals don't take into account, and the larger population doesn't take into account. And there's actually quite long-standing evidence that speaking about a positive benefit-risk balance actually makes it worse, because it means that there is a risk. It actually focuses on the risk. And so it's actually that healthcare professionals like to speak, but it's probably not a good idea. And you can do a motivational interviewing process, and you say this, and maybe it's the element that will stop the process, and actually, so it was not a good idea. So we are also currently working on tools that for content and motivational interviewing. And so this is a European level study that tries to evaluate in a pragmatic way what can be done to improve healthcare professionals' skills. And so there will, of course, be an eye training, but also the question is, isn't there something that could be that needs to be used so that actually the start of the consultation is better? So how can the healthcare professional actually get the information about where the patient is, where the patient stands, in terms of vaccine acceptance, where are the elements that drive this hesitancy, and without doing all the catalog of questions. And so our idea is to have a tool, a short questionnaire that can be filled out before the consultation, and also include some scenario-based acceptance profiling. Here, for example, presenting 5 scenarios, and you that on the vaccination that differs by effectiveness, epidemic situation, and so on. And then you observe just how the patient actually reacts to these different scenarios, which is already a useful information for the healthcare professional to even start the conversation. Also, it comes from the observation that in the discrete choice experiments, actually people like it because it makes them think. And probably what we want with MI in the consultation is have everybody think a little bit out of the box. And then the other point is using, for example, the 7C profile. So you probably have heard about the 7C model with the different components that go into vaccine acceptance or not. And why not have a short questionnaire that actually allows the healthcare professional to get an idea of where is the patient, where are favorable attitudes, and where are rather unfavorable attitudes. So that's something that we are dreaming of. We're working on this, and maybe one day we can really evaluate it. So now, the problem in all this is that healthcare professionals are not all for vaccines. And just remaining on the 7C tool and COVID vaccination here, you see that if you have this profile, the 7C profile, on the outer lines, it's the medical doctors. They are overall, on average, more for vaccines. Other biomedical professions are also quite favorable to vaccinations. But if you speak about nurses, who actually should be really a key actor in vaccine promotion, they are quite on a different page on vaccine attitudes. And so what can we do here? We also need interventions, probably. But which attitudes actually should be improved? Where are the critical attitudes? And it's not just because an attitude is frequent that it needs to be addressed. It's not because an attitude is closely associated with vaccine acceptance or vaccine promotion that it needs to be addressed. It's actually the combination of both. It's only the quite frequent negative attitudes that are closely related to acceptance that should be addressed. And we also should keep this in focus, that we need more data on this. And here, so again, COVID vaccination and healthcare professionals, their intention or their status it was along the COVID epidemic, and so over time. And you see that there's actually a few of these 7C items that constantly are responsible for this reduction or loss in coverage and intention. And the one that really stands out is the confidence in the vaccine. I'm afraid of having a severe side effect from this vaccination. Also, I think that the vaccination has more benefits than risks for me, so they are mutually adjusted. And yet another one that quite constantly is relatively important and leads to losses in the coverage is the agreement with vaccination is also a collective action to stop the epidemic. So healthcare professionals not always agree with this, and it leads to losses in coverage. Can we improve these attitudes? That's really something out for research. There's no evidence that we can. Well, there's some tools that we have, and so again, a study by Pierre about the Pro-VCB scale. It's actually quite good because it doesn't only look at healthcare professionals' vaccine hesitancy, if you want. Here it's a score with 6 items. There's no social conformism in here, but otherwise it's very close to the 7C scale, the model that I just showed you. But in addition, there is this other package here on their professional activity in healthcare promotion. So it's proactive efficacy that has different components in here. And so actually the question is, does interventions, for example, MI training, does it have an impact on healthcare professionals, which is really one of the big questions. And so here there is a study that also Pierre conducted to evaluate this. Does MI training improve the score in medical interns? And what you see is there are significant and substantial improvements in the proactive efficacy, so the way that healthcare professionals or these young professionals see their role, how they are confident to be able to play the role. However, it doesn't actually really change a lot on their own vaccine attitudes. So, which is maybe not a problem if they are really able to separate the two, but the question is also how can we actually improve these attitudes among the healthcare professionals, and here we don't have much interventions. So, if we speak about interventions, there's interventions that focus on policy, there are interventions around the medical practice, there are interventions needed around healthcare professionals' attitudes. Now, what are the outcomes? This is where it gets complicated. We need, as the outcomes for our studies, vaccine acceptance, 7C, Pro-VCB, but also skills, satisfaction, self-rated practice, vaccine hesitancy among the patients. That's what we're actually out to work on. Self-reported success rate, uptake by previously unvaccinated individuals, and from a public health perspective, what we actually need is coverage rates in the population served by these healthcare professionals. And this is actually the best for like evidence level. And as well, often we work with pre-post change, we do need controlled design, and the best would be randomizations. So that is sort of the challenge that we have. I would like to speak a little bit about the Prés HPV trial, which is a trial that's happened in France around HPV vaccination. It was a project that happened in several regions of France. The objective was to evaluate effectiveness, efficiency, and the implementation of 3 intervention components, alone or in combination, which is was a cluster randomized trial. The clusters were communities or municipalities, communes. There was school-based intervention and then also training for the GPs. It was a partial factorial design so that not everybody, we didn't have vaccination in schools without prior education which could have been done, but which was not the choice. And you see that some of the arms had a training on the GPs. And so 91 municipalities were randomized, and the analysis happened for overall, but also accounting for the intervention intensity, because, and here is the first problem, well, not only some schools dropped out, but actually in the communities, in the municipalities that were randomized to have GP training, only 20 to 30% of the GPs participated. Big problem for interventional research. So we have to adjust in the analysis for this fact. And so we had a GP team who developed interventions for this. There is a training on motivational interviewing, and Aurélie Gaucher will speak about this this morning. There was a development of a shared decision-making tool according to the guidelines with stakeholders, very nice shared decision-making tool that had pictograms that made it very easy to speak about vaccination. And here are the results. So this is the coverage measured by reimbursement data among the 11 to 14-year-old children living in these municipalities who participated. In the principal analysis, you see it's only the school-based campaign that showed significant effect. There was no effect of the GP training. However, once it was adjusted for the intensity, so taking into account that there was only one or none of the GPs in this municipality who got the training, you actually do see an increase. It's not huge. It's a 4% increase in coverage at 6 months, so it takes a little bit more of time. But, well, is this a lot? Actually, if you look at the literature, yes, it's what you see in the literature. And that's another challenge. The increases that we can expect are not huge in interventional research. They're often around 5%. If you tell a decision maker, we need this because it increases the coverage by 5%, this is not ideal, but it's, according to the literature, what you can demonstrate in interventional research. We also looked at used questionnaires to look at what actually changes in the attitudes and practice of the GPs who did the training, which leaves us with a sample size of 32. That's the other problem, not many people, and we didn't have any control group because it was considered not, well, feasible to enroll GPs, do all this, and then actually not give them in the intervention. So we only have before-after comparison, and so this is a percentage of GPs among the 32 who had a favorable change following this training. And the other problem is those who participate are already at the maximum level of being favorable to HPV, because those who are not favorable, they don't even participate. However, we had a few points where they were not completely perfect. Systematic recommendation to boys, where we could increase the median score, and actually 30% of the participants did show this favorable increase, the favorable change. Having enough time to speak about it, 50% improved. It is priority in my consultation, 50% of the, 30% improved this. A little bit more on the female side than on the male side. Evaluating the ease in arguing on the vaccine safety, 50% increased here, and the feeling of being independent from colleagues' opinion on HPV vaccination also increased in over 50%. So you can demonstrate a little bit of an increase, but these are the favorable ones. What about all the others that are not so favorable about HPV vaccination? We don't know, because in tendency they didn't participate. So the difficulties that we face with this, this interventional research around improving the vaccine promotion by healthcare professionals is the recruitment of volunteer healthcare workers, in particular if it's about physicians, MDs, and general practitioners, especially if you want to work not only on the highly motivated champions. You need, in the funding, you need to budget in indemnization for the healthcare professionals, especially if you work with physicians. The assignment to a control group without intervention may not be acceptable or not attractive to the healthcare professionals. You actually would need to focus on the healthcare professionals with high vaccine promotion activity, and those who see the hesitating patients, which is something that you have to do probably upfront, to focus in some ways in the design, to focus on them, the situations where you have this. The before-after comparison in activity and the coverage is actually challenging. If you study a seasonal vaccination like flu, then your before-after design really gets challenging. The expected increases may be small. Uptake and coverage are more difficult to observe, although they are actually what counts, but you need reimbursement data or quite cumbersome accounting for follow-up with vaccination activity. And we know that complex intervention are most promising, but as I showed you with this cluster randomized trials, if you combine school-based and physician-based intervention, it also leads to the most complex evaluation designs, and you better be accompanied by somebody on these methods, on more complex trial designs. Thank you very much.
There is some question. I don't know there.
So thank you very much, John Krakowski from Global. So in your opinion, despite the fact that we observe small increase in the vaccination rates through a multimodal modality, do you think that the only way to have a huge increase is to have it from a regulatory point of view, to impose vaccination?
So why are these increases so small? I think it's within the concept of interventional research and all the constraints that you have. It's relatively short as a follow-up, and so there's something in there. It's difficult to, if you do best practice research, it's difficult to show higher increases. The problem is clearly on both sides, the healthcare professionals, the population, and also the third level, that is policy. So I can't make a strong affirmation here, but I think you would need all three levels to work together to have a strong increase. So we can discuss what is happening with HPV in France. It's probably a combination of all of them. It's a policy change with going to schools. It's better information of the population. There's a buzz made around HPV with a good campaign from INCA, but also there's a lot of training of healthcare professionals going on, not only like in the PrEF-HPV trial, but I think at the university from the professional societies, there's a lot of improvement made. And not to forget, MI is generic. If somebody gets training on MI for cardiovascular disease, it probably also has some impact on vaccine promotion. So a combination is needed probably, yeah.
Thank you. That's a really lovely summary, excellent talk. I was wondering about the small increases in interventional that the interventions have, and I wondered how much of that is the fact that one single intervention will not work on all of the people. So how much do we need tailoring for different groups? So as an example, we know that the presumptive approach on the population level is very good for improving rates because people see that as a recommendation, but it could be less effective if people are really hesitant to begin with. Yeah, so that's the question whether there's a niche that actually drives the low coverage. I turned to Pierre. The doing study among the most deprived population is probably what we need then, not only these, often journals ask, for a sample, representative sample of the population. For example, for the PrEF-HPV trial, we were criticized because we didn't have a representative sample of schools and so on. Yeah, but it's really difficult. But actually what we need based on it works, it doesn't work doesn't have so much great impact. Indeed, I think the next step is rather going into focused situations and showing that it works there, which doesn't make it easier then to do the research. But I agree, you should focus into specific populations. Yeah.
Thank you for that great presentation, Judith. Really comprehensive. Katie Atwell from Western Australia. My question sort of returns to the first question and in building on your response to that. It struck me, listening to your talk and thinking about the different levels that you spoke about, that we're not paying enough attention to the policy level. And having compared France's vaccination system to that of other high-income countries, what really strikes me, and this was really reaffirmed by what you said in your talk, is that this is a country that relies heavily on vaccine mandates to get the most of the childhood program into children, and a sense that vaccination is not really a government responsibility. It's actually kind of put back on the consumer and then so much on the shoulders of the healthcare professionals. And so much of this is about behavioural interventions, either with them or with the public, but we're sort of not paying attention to the fact that the reason we're having to try so hard with these behavioural interventions and really plug away at this intervention research is that there are massive problems with the French system that are overcome for the childhood program only by having these really strict mandates. So I guess I'd be interested in your reflection on what I've said and whether you agree, and if so, what are the barriers to building a greater sense of that vaccination is government business, and for example things like having teams of government workers that go out to vaccinate kids in schools for HPV, which is done in many high-income countries. Like, why isn't there more of a push for these sorts of structural policy changes?
Yeah. So what can I say? So personally, I'm not in favor of, very personally, I'm not in favor of any mandate, just to position myself. I think France has made huge progress with this policy engagement, government engagement, and health authorities engagement into vaccination. 10 years ago, it was worse, much worse. There were programs defined what should be done to improve, and this was gradually implemented. So I think there is a way forward. Then suddenly this mandate came in. So that would be another talk, why we have this mandate, because it's actually a millefeuille. There are many different reasons. There's not one single one that completely explains why it is there. To give you a short answer, I think the mandate in France is actually a very strong intervention to improve acceptability of vaccination. and not because people are forced, but it gives it a better profile. It's seen much better by the population, because there is a mandate. And researchers have discussed this, that there were evidence to show that only vaccines that are mandatory are seen as important and seen as the public, the government, the authorities take the risk to make them mandatory, and this means that they're really important. So it's not a mandate like, again, I'm not in favor of mandates, and I would like to see this handled differently, but the main feature of this policy is to improve the attitude of the population around vaccination. And given the increasing rates of other vaccines that are not covered by this mandate, like HPV vaccination that started quite soon after increasing the coverage, there may be even, this may work, not only in theory, but actually also in reality. So the question is, should the mandate be taken away, which could be topic for interventional research, but I doubt that anybody would dare it. So the way forward is not clear, indeed. Oh, so yeah. So I read it. When we think about healthcare professional attitudes towards vaccine promotion, have we ever done any research to look at the effects of MI-type interventions to improve this with healthcare professionals themselves? So I think that's what the study by Pierre did, where they looked whether MI techniques, training on NI techniques improved in medical interns their capacity to promote it. On the other hand, of course, if it's about their own vaccination, it's clear that you need MI, and especially the Vax Action study that I showed you. We plan to evaluate this intervention with the MINT and SMART pieces to evaluate it also in occupational medicine context, where for the flu vaccination in France each year, the winter season, unfortunately, healthcare workers remain largely unvaccinated. So it's also a situation. But my talk here was more about the vaccine promotion by healthcare professionals. So there is a quite substantial body of research looking at this, how much MI actually helps the promotion of vaccination towards healthcare professionals.
Okay, thank you, Judith. I just wanted to make two short comments on 2 points. First, the effects of the mandates, the childhood mandates in France, and the other one on the limited effectiveness in terms of percentages of different interventional approaches. For the first point, indeed, since 2018, we have observed an improvement of vaccine coverage overall in France for different vaccines concerning childhood. But if you look at it in more details, and especially if you look what happens regarding children from non-poor families, sorry for the term, low-income families, and what happened for those from not low-income families, we can see that in fact the mandates might have increased social inequalities, in fact, because what we saw is that the coverage in children from low-income families did not increase as much as for the other children first, and also we also try to study this problem not in terms only of coverage but also in terms of delay vaccination compared to the dates recommended in the schedule. And what we saw, this is not already published, but we have submitted an article to Eurosurveillance, that there is still a delay for all the population, which is about 6 months, the 2 doses. For measles, for the 2 doses, there is a 6-month delay compared to what is recommended, and this delay is even greater for children from poor families. So there is a problem here, and probably a question about what are the reasons why those children would be less receptive to this kind of policies, which should be addressed both in terms of research, because this population are rather diverse also, and in terms of response, and especially also in terms of anticipating this new kind of policy when they are launched. First thing. The second comment I wanted to make is about the limited percentage effectiveness of the different, I would say, techniques or approach. I just wanted to speak about motivational interview because I've worked on with Arnaud Gagneur. Arnaud Gagneur is somebody, a researcher in Quebec who has adapted motivational interview to vaccination, and he has tested it in the frame of maternities, and he showed an impressive result. In fact, it was not about 4% or 5% increment in vaccination, but 10 to 12% increment in vaccination, starting at a level which was in Quebec rather high already. So a rather impressive result. And I think one of the explanation of this impressive result is not only linked to the use of motivational interview. This is also a strategy. This is not only a technique, this is a strategy. And the strategy is to train people who will intervene in maternities and propose motivational interview for each woman who has given birth to a newborn. And these people are not only trained to perform motivational interview, but they do it daily, every day, several times. If you train GPs in the community, yes, they may be interested. You might have kind of heroes, but in fact, most of them will use motivational interview from time to time, not so much often. They will not be able to practice motivational interview as well as is desired to obtain an effect. So the thinking an intervention in terms of strategy, not only in terms of technique, which technique would be efficient, but what are the conditions given the context that may make it more efficient given the organization is also probably a way we should think interventions. This was my...
Yeah, just to reply to this, indeed, but it's actually a policy change, having other people coming in and bypassing in some way the physician activity. And just to also come back to your comment, I think the question about mandatory vaccine offer, maybe mandatory physician visit and mandatory vaccine offer, I think that's something where I would rather see a mandate work and probably could have a rather strong impact. Yeah. Thank you.
Yeah, thank you very much, Judith. And just to bounce off on what you discussed and Pierre also, is just in one of the results that you showed, there were some good results with the motivational interview with midwives, and so I'm just thinking how broad can you go, because we know GPs have a lot of things to do and so on, and so we're kind of diversifying who can do it. But in the spirit of what you were saying, what is the best kind of interactions where you can strategically put motivation in an interview? I was wondering, in kindergarten, the people who take care of kids, can you go more broadly beyond healthcare workers, or when does it go too thin in terms of legitimacy to discuss these things?
Yeah, it's probably a trade-off between efficiency, like who has the time to do this, which is one of the big constraints about MI, and on the other hand, without broadening the range of people who can do it, but without losing on the quality side, the training side, and very importantly, the confidence side. Because why does MI in midwives work? It's because they are healthcare professionals and people credit them a lot on technical aspects, safety questions, and so on. If you go too far outside, you may lose on this side. So probably there's something to balance out. Probably, unfortunately, in each setting, there is a specific answer to this. So more research is needed.